Thank you for joining us today for our Understanding the Severity of Your Food Allergy webinar. I am Jennifer Gertz, Executive Director of Food Allergy Canada, and our guest speaker today is Dr. Philippe Bégin. Before I outline today's session and introduce Dr. Bégin, I have a couple of housekeeping notes that I'd like to cover off. Please note that this session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. Thank you to everyone who submitted questions in advance. It's helped us to inform today's session and the questions that we'll be addressing. That said, if you have questions throughout the webinar, please submit them in the chat box and we'll try to get to as many of them as we can. This webinar will be recorded and shared on foodallergycanada.ca afterwards. Now, a little bit of background on today's session and format. Historically, the approach to the discussion of food allergy has really been a binary one. You're allergic, you're not allergic, and anaphylaxis is considered a very possible outcome, and we understand anaphylaxis to be potentially life-threatening. It's not uncommon for individuals with food allergies to be asked, how severe is your food allergy? In an effort for others, whether it's schools or restaurants, to understand just how sensitive you might be to your allergen. And I can attest to the frustration of this question since the answer is not clear. It's not surprising then when you hear people describe their allergy as an anaphylactic allergy in an effort to communicate possible severity. But in reality, we don't have an answer to that question of how severe our allergy is, and we reference that worst reaction that we've experienced, while being ever aware that it's possible that a more severe reaction could happen on subsequent exposures. With research and the evolution of oral food challenges and immunotherapy in allergist practices, much more is known about this subject that might help us understand our questions on severity. So the format for today's session starts with a presentation from our expert, a 20 to 25-minute presentation, and then we're going to tackle questions that were received from you that are bucketed into some themes. So we're going to start with some background context from Dr. Bégin, defining some key concepts around what is food allergy, the biology of a food allergic reaction, how do we define severity, anaphylaxis, and thresholds, and then we're going to get into some Q&As, really digging into some themes around exploring thresholds and how that might relate to severity, diagnostic approaches to understanding thresholds and prediction of severity, what might be done to decrease the severity of food allergy, and what are the implications for managing food allergy. So we are delighted and feel privileged to have the expertise of Dr. Bégin. Dr. Philippe Bégin is a clinician-scientist and associate professor at two hospitals, the CHUM, which is the University of Montreal Health Centre, and Sainte-Justine, the largest mother and child center in Canada and affiliated with the University of Montreal. He also teaches allergy and immunology at the university as well. Dr. Bégin is a director of a public oral immunotherapy clinic at the Sainte-Justine and is recognized as an international expert on multi-allergen oral immunotherapy. Dr. Bégin is also on the board of the directors for the Canadian Society of Allergy and Clinical Immunology and is a member of the Healthcare Advisory Board for Food Allergy Canada. Dr. Bégin, we're delighted to have you join us and help us explore this topic more in depth. Over to you.
Thanks, Jennifer, and hi, everyone. So today I'm going to talk about, food allergies, so my favorite subject, more specifically on the question of severity. So Jennifer really outlined very well the challenge of defining severity in patients with food allergy. So just before we get started, those are my disclosures, but none of those relate to the present talk. So first, we're going to just go through the biology of food allergy. So what is a food allergy? How does that work? Then we're going to talk a bit more about how to define the severity of a food allergy, explore the concept of thresholds, and at the end, just a bonus, I'll just show you how oral immunotherapy works. So how does food allergy works? So food allergy, because any allergy are immunologic diseases. So it all starts with white blood cells that decide that, whatever allergen is bad. So normally when white blood cells recognize something that's dangerous, they're going to make antibodies. They're going to make the regular antibodies, which are called IgG. So when you get vaccinated for COVID, you're making IgGs. Those are the regular antibodies. And what they'll do tons of stuff, but one of the things they do is they cover the bacteria. So here you have a white blood cell and the two black dots, that's a bacteria there. So it targets it so the white blood cells can eat it, digest it, and well, kill it. So the problem in evolution was that our ancestors encountered parasites. And parasites, the problem with those is that they're really big and they can't be eaten up by white cells. So even if they try, they can try to eat it, but they're never going to succeed. So in the evolution, we needed a new type of weapon to defend us against those parasites. And that weapon is the IgE antibodies. The IgE antibodies are the antibodies that cause allergy, but in evolution, they're actually there to protect us against parasites. So the IgE antibodies, what it does, it is going to arm the mast cell. The mast cell is a cell that's all over the body. Whether you're allergic or not, you have mast cells all over your body. You can recognize this a mast cell because of the big black dots there. Those are bags full of histamine ready to explode. So you need to imagine the mast cell basically as a landmine just waiting to be triggered. And the IgE, what it does is going to arm the mast cell. So when we draw antibodies, we always draw it as a Y. So the two tips at the top, they recognize whatever the antibody is against, and the bottom of the Y is going to bind the mast cell and arm it. So what's going to happen is that, let's say in your skin, when you have a parasite that's going to crawl under your skin, when it's going to touch the mast cell, kaboom. So it is going to explode, release its histamine, and trigger a local reaction. So imagine that you have Tarzan in the jungle and he gets a parasite in his foot. So what's going to happen? Well, everywhere where the parasite touches those mast cells, they're going to get triggered, they're going to release histamine. And what does histamine do in the skin? It itches and swells up, it makes the skin become red. So you can imagine that Tarzan doesn't cut his fingernails, so he's going to scratch because it itches up, and maybe, hopefully, he's going to be able to get that parasite out of his skin, because the white blood cells can't eat it, but you need to find some way to get it out of the body in another way. That's what histamine does in the skin. In the gut, what it does is going to increase peristalsis, so it's going to make you vomit, and it's going to cause diarrhea. So again, a reflex of getting whatever's there out of your system. In the lungs, is going to close the bronchi, secrete mucus, and trigger a cough reflex. So you can imagine that if you cough on a bronchus that's closed, it's going to really propulsate, it's going to push the invader out of your lung. So it's a very effective mechanism to get rid of an invader if it's localized to one lung, one part of the lung. If it's all over, then it's not so good because you can't breathe anymore. But localized, it's actually an effective mechanism to defend you. In your eyes, your nose, your throat, it's going to itch, it's going to make you sneeze, it's going to make you cry. So all those are reflexes to, again, get that parasite out of your system. Now, the problem today is that Tarzan may have become allergic to peanut butter. So his white blood cells made the mistake. They saw peanut protein as a dangerous parasite. So he produced IgE, which armed all of the mast cells of his body. What's going to determine the symptoms is where that allergen or the parasite is going to touch the landmines. So peanut is a food, he's going to eat it. So what do you expect to see? It's going to itch in his mouth. Then he's going to swallow it, it's going to go in the stomach. So he's probably going to get a tummy ache or potentially vomit. But let's say he doesn't vomit immediately. What's different between a food and a parasite is that you're going to digest the food and absorb it, and it's going to go in your bloodstream and get distributed throughout your body. And when that happens, the allergen can trigger all the mast cells of your body. And this is when we get anaphylaxis. So when you hear about the definitions of anaphylaxis, or when you're looking on an action plan for a food allergy, you're going to see anaphylaxis defined as a combination of different symptoms from different systems. So that's a technical definition for anaphylaxis to help you recognize it rapidly. But biologically, what anaphylaxis is. It's an allergic reaction to an allergen that is in your bloodstream. It's getting distributed throughout your body, and therefore it can activate any mast cell, any landmine, anywhere in your body. That's why it's potentially dangerous. So you're going to get anaphylaxis to allergens that will enter your bloodstream. You're not going to get anaphylaxis to your cat allergy or to pollen allergy. You get anaphylaxis with food allergy, with insect sting, with medication. You could get anaphylaxis to cat if you inject the cat, like when you do allergy shots. Then you can get anaphylaxis. But otherwise, your allergy to cat is only going to trigger reactions where the cat allergen is going to touch your mast cell, your eyes, your throat, your lungs. It can still be severe, but it's never going to be anaphylaxis. So when we talk about anaphylaxis, we always, it kind of gives the message that this was a strong, severe reaction, and people say, oh yeah, I have anaphylactic type allergy. For me, anaphylactic type just means that you have the regular type of food allergies, because there are other types of allergies that are not mediated by the IgE antibodies. The white blood cells are causing trouble by themselves, for example, in FBIs. So for me, that's what it means, anaphylactic. Anaphylactic does not necessarily mean severe. So this is a common misconception, anaphylaxis meaning severe. Here you have grading of severity of anaphylaxis. This is for research purposes, so you really don't need to learn this. I just wanted to show you that you can have mild anaphylaxis. If a patient has a hive on his arm after eating peanut, the peanut didn't touch the arm. So the only way that it could have triggered that hive is because you ate the peanut, you digested it when your bloodstream, and through your bloodstream, it reached your skin. So technically, this patient is experiencing anaphylaxis, but it's mild. Usually the criteria to treat, those that you learn or that are in your action plan, they consider moderate anaphylaxis. So usually 2 symptoms from 2 different systems are involved, or 1 symptom from a vital system, like for example, if you're getting an asthma attack. If you're getting an asthma attack because you're in contact with a cat, it makes sense to treat it with a bronchodilator, so you give 2 puffs. But if you're getting an asthma attack after eating peanut, you didn't breathe in the peanuts. By definition, you ate it, you digested it. When your bloodstream is through the bloodstream that it reached your lungs. So therefore, the treatment also needs to be through your bloodstream. That's why you need epinephrine. Even if you have your pumps with you, your inhalers with you, you should still give the epinephrine in that case. And I think that one thing that really causes confusion is that people confuse anaphylaxis with anaphylactic shock. Shock in medicine, what that means is that your blood pressure goes down, actually goes down so much that you're not getting blood to your important organs, such as your brain or your kidneys, for example. So anaphylactic shock, yes, that one is life-threatening, but it's actually extremely rare. So even in patients that die from anaphylaxis, only 20% actually had an anaphylactic shock. The 80%, the other 80% actually died from severe asthma attack. So anaphylactic shock is really the patient lost consciousness because the blood pressure went down. So this obviously is life-threatening. But even a patient that has mild symptoms, you could treat with epinephrine. So even if you have only hives, it's all over your body, but you don't have another system that's been touched, you could still treat with epinephrine. Epinephrine itself is not dangerous. Epinephrine is just the treatment for a systemic reaction for anaphylaxis. So anaphylaxis doesn't mean severe at all. So how do you define the severity of a food allergy? So clearly, severity of a reaction has nothing to do with the severity of a food allergy. Actually, in the right circumstances, even non-allergic people can have anaphylaxis. For example, I don't have a food allergy, but if you give me morphine and then you give me a transfusion of iron during my pollen season, I'll probably react anyway, even if I'm not allergic, because the mast cells will have been activated, not by IgE antibodies, just because we just tickled them so much that at some point they end up reacting. So you have some people that spontaneously have hives without even having allergy. So how do you define severity in food allergy? Well, maybe one definition could be the likelihood of anaphylaxis happening. But the problem with this is that most of my severe patients, the ones that I consider to be severe, oftentimes will tell me that they never have reactions because they're so careful. So the likelihood of a reaction happening might not be the best way to define the severity of a food allergy, because it really depends on the patient's behavior. And it would basically mean that the patient that's not being careful, getting lots of reaction, is more severe than the one that's avoiding them. But you can imagine that the one that's avoiding the reaction is the one that's most severe, and that's why he's avoiding it. So I think that maybe a better definition of severity could be the likelihood of anaphylaxis happening if you are exposed to your allergen. And that would be probably the best biological definition of food allergy severity. So the problem is that, contrary to another disease, when you're actually always experiencing that disease, you don't know how severe or what the risk of reacting is to your allergen unless you get exposed to it. So that really creates a challenge in defining the severity of a patient's food allergy unless he's just had a reaction with his food allergen. So how can you predict that risk? So obviously we can use allergy testing. So there are two ways to test your allergies. Most of you must have had the skin tested, but a lot might also have had blood drawn, where we actually measure the IgE in your bloodstream that's specific, that recognizes your allergen. So the more IgE against the allergen in your bloodstream, the more there will be of those IgEs on your mast cells, on your landmines, so the more likely they are to react with a smaller amount of the allergen. But obviously that's not perfect, that's just a number, and there are tons of other factors that will impact whether or not a mast cell will activate or not. The skin test, the idea behind the skin test is actually to trigger those landmines. So what we're going to do is we're going to put the allergen on your arm. We're going to scratch your skin so the allergen penetrates the skin, and then it's going to meet the mast cell, it's going to meet the landmine, and then it might make it trigger. The thing is, this is really not physiological. So when you do a skin test, you're actually flooding the mast cell in the skin, the landmine, with the allergen. When you're eating peanut, for example, you're going to digest it. Only a minute amount of it will actually enter your bloodstream and reach your skin. When you're doing the skin test, you're bombarding it with peanut. So even if your skin test is positive, it doesn't mean that you have severe allergy. It might not even mean that you have allergy, because when you eat the food and digest it, the amount that's actually going to reach your skin is too small to make you react. But if the skin test is negative, then that has a very good predictive value. So it's very unlikely that someone is allergic if the skin test is negative. And it's even more unlikely that that patient would have a severe allergy, because some patients do react despite negative skin tests, but usually it's not severe anaphylaxis. So on the negative sides, the tests can be useful. But the gold standard to measure the biological severity of a food allergy is really the food challenge. So how do you interpret the results of a food challenge? So for those that don't know, the food challenge is your allergist is going to have you come in clinic, and they're going to give you a tiny amount of the food, then see if you react. If you don't, 20 to 30 minutes later, they're going to give it a little bit more, and then a little bit more, until we can find the threshold that makes you react. So how do you interpret the results? Well, there are two factors here. How much food do you need to trigger the reaction? So that's what we call the threshold. And then the severity of the reaction. And that's something that's a bit tricky, because it's hard to tell what's worse. Someone that had a reaction that was very severe, but with a large amount of the food, or someone that tells you that they had a reaction with a tiny trace amount of the food, but it was a relatively mild reaction. So in research, what they do is that they make you keep going with the challenge until you reach at least moderate reactions based on the criteria I showed you earlier. So that way it standardizes it a little bit, and we can see the threshold change with treatment, or remain the same without treatment. And then we can see that there's really a big difference between individuals. So some patients will have very high threshold. They require 25 peanuts for them to react. Some patients will react to only a trace amount of the food. So here I have some curves of studies where what they did is just they took patients that had peanut allergy, so they had a history of reaction, they had positive tests, and they challenged them, and they found their threshold. And what you can see is that when you do that, about 20% of patients are actually tolerant. So they can eat peanut, even though they have this history of reaction positive test, they're not allergic when we actually test them. And 60% of the patients will actually tolerate half a peanut. So that's very interesting because at half a peanut, you're at least 10 times above what is the trace threshold. So this is someone that may not need to be avoiding trace, for example. So this is something that obviously changes your perspective of the severity of your allergy if you know it. For shellfish, the false positive rate is 30%, and 90% of patients can actually tolerate one shrimp without reacting. And for soy, that's the worst one. We have 80% of false positive tests. The reason is because it's a legume. So usually patients with peanut allergy also get a positive test to soy, but it's really your allergy to peanut that's making your test come up positive with soy, but you can actually tolerate soy. But even in those 20% that do react to soy when you do the challenge, 40% can already tolerate 10 milliliters of soy milk spontaneously without doing any treatment, without doing any immunotherapy. So obviously, if you're going to consider treatment for these patients, well, it completely changes your perspective. You're not going to have to start with tiny amounts and work your way up to a large amount. If you can already tolerate half a peanut, well, you're usually going to start your immunotherapy with half a peanut, and that's it. And this is probably why we're more interested today in severity than we were before. Before, the message was avoid your food, so whether you're severe or not, just avoid it, and here's the epinephrine. Now we're considering treatments, and depending on the severity of your allergy, it might affect your decision to do it or not. It might be harder or easier, or so now we're actually considering these things, which we didn't before. True or false? Thresholds can vary over time. So we don't have a poll, so I'll just give you 5 seconds to think about it. And the answer is that it's true. So thresholds can vary over time, and that's what we've been saying because we know that it does, but not as much as we thought before. So it really changes, but only to a certain degree. And this is something we've learned from all these new interventions we're doing now where we're doing clinical trials and patients are in placebo for 1 year. So you do a challenge at the beginning of the treatment of the study, and then you do a challenge at the end of the study. And the patients that were in the placebo group, surprisingly, they're really reacting exactly in the same way, the same symptoms. So if you vomited at the first time, you're going to vomit at the second time. If you had an asthma attack, it's going to be an asthma attack. If it was the skin, it's going to be the skin. And they're usually reacting at around the same dose that they were before. So the threshold does change, but not that much. And in practice, we say, it can change maybe by tenfold, but let's say that someone is tolerant to half a peanut, that's 125 milligram. It's very unlikely that just by chance, by this threshold changing, they're going to start reacting to something that's 10 milligram or lower. So oftentimes, this is a level where we'll say okay to traces, so to trace amounts. So these patients will be allowed to eat food that may contain trace. And when we do oral immunotherapy, usually 100 milligram is the threshold where we give the green light for that also. One exception to this that we've learned with oral immunotherapy is cofactors. So what are cofactors? Cofactors are things that affect your threshold. So there's 2 ways it can do this. So one way is that it's going to stimulate your mast cell. So because it's another stimulation to your mast cell, it's going to require less IgE on its surface to get activated for it to blow up. So for example, if I'm in my pollen season, I'm already stimulating my mast cell with my pollen allergies. So my threshold is actually lower. And what's usually I'm able to tolerate 2 peanuts, now I can't. I'm going to react to that dose that was usually fine. The other mechanism that we see with cofactor is stuff that's going to interfere with digestion. So the best example is exercise. When you do exercise, it because of the heat that accumulates in your stomach, is going to break down the barrier of your stomach, and it's going to allow your allergen to pass directly in your bloodstream. So usually when you eat the food, it's going to take about an hour for you to reach a plateau in your bloodstream where you have a stable concentration of the food, and then after 3 to 4 hours, it's going to start going down. Let's say that you eat the food, and then an hour and a half later, you go for a run. There are still, let's say, peanuts in your stomach, And then because the stomach barrier is broken down, the allergen is going to enter your bloodstream suddenly, and it can trigger reaction because all of a sudden you're exposed to a higher concentration of your allergen in your bloodstream that you were before. So classical cofactors are exercise, if you have fever, if you're in your pollen season, if you take alcohol, if you take anti-inflammatory drugs. So in adults, so I don't do that in children, but in adults, we actually do cofactor challenges. So what we do is that we have the patient come into the clinic, and we know that the patient has a very high threshold to his allergen or tolerates the allergen. But the question is, can I tolerate the allergen even if there's a cofactor there? So we have the patient take 1 gram of aspirin, 30 ml of pure alcohol, 95%, which obviously can be diluted in orange juice, and then half an hour later, we give them their allergen and see if they react or not. And half of the time they do react, half of the time they don't, but they're always happy to have done it, because even if they do react, those are usually patients that are on oral no therapy. What they tell us is that, I don't mind being careful with cofactors, but I don't want to be doing it for nothing. So if I have to avoid alcohol and sport after taking peanuts, I will. But if I don't have to, I just didn't want to do it for nothing. So just getting informed on their threshold and their cofactors is something that improves their quality of life. And talking about quality of life, this is the other aspect of severity that we need to consider, because I just talked about the biological severity, which you can kind of define as a threshold, but does that necessarily translate into consequence of living with that threshold, with that risk of reacting? And the consequence on your daily life depends on how you react to this information or how you interpret this information. So this is the anxiety equation, and you can put whatever there. It doesn't need to be food allergy, but let's say that we're talking about anaphylaxis here. So how do you calculate the level of anxiety of a patient? Well, you look at the perceived risk of anaphylaxis happening times the perceived severity of it if it was going to happen, divided by your perceived ability to cope with it if it was going to happen. So as you can see, perceived, perceived, perceived. So anxiety is all a question of perception. And you might have had conferences by allergists that tell you, you don't need to worry about your food allergy. There's a greater likelihood of dying from lightning strike than from your food allergy. And technically, that's true. And those that live the best with their food allergy are usually allergists that are themselves food allergic. And oftentimes they don't really understand why we want to treat it, because they have a full life and it doesn't really matter. But they're experts. So obviously they have a high confidence in their ability to treat the reaction properly, and they have a very good understanding of the concept of threshold, and they can analyze the risk. This is very different from the non-expert patient, the one that just got the diagnosis. So even if you tell them the risk is very low of reacting, yes, but it can happen, and the consequence is very bad. So, and because they cannot estimate this risk in their daily life, it impacts their quality of life. So they end up living with a lot of anxiety, and they limit themselves in their day-to-day lives. So how can you improve the quality of life of a patient that has food allergy? So the only way to improve your quality of life is to get to know your allergy. Food allergy, the problem with it is really an issue of control. If you're an expert patient, even with your food allergy, the food allergy doesn't control your life. So usually you're going to live well with it. But if you're not an expert, usually you have a feeling of loss of control, and this is where you lose your quality of life. So how do you get this experience? How do you get this control? One way is just, well, with living with the food allergy. So oftentimes I'm going to see adolescents or young adults tell me that, I'm fine with my food allergy. I live well with it. The problem is my parents. They go crazy. So last week I had a reaction. So I just ate the food. It itched a little bit in my mouth. So, oh, I'm reacting. They went crazy. I told them, no, it's fine. I know my body. I've had this before. We're not at the limit where it's going to go bad. I know when my body reaches that limit. And when I know the anaphylaxis is coming, I know that I need to give myself the epi. At that point, I wasn't there. So this is a patient that has gained experiential knowledge that even me as a doctor, I can't give to someone. That's really by living with your food allergy, they really get to learn about their own food allergy. No one else, even someone else with food allergy, cannot do that for them, because every food allergy is different. So obviously you can have this, and what we see is that patients that have experienced reactions usually have a better quality of life overall than those that have never experienced reactions, probably because they have had this real life experience. If you don't have this experience, what you can do is food challenges. So studies really show that if you've had a food challenge, whether you've reacted or not, you're going to see an increase in quality of life just because the patient knows what the reaction is. So a patient that has never used the epinephrine, that has never had a reaction, all that they know is that food allergy is potentially fatal, but they don't know what to expect. So just having them go through the experience can really improve their quality of life. And another way is oral immunotherapy. So how does oral immunotherapy work? So oral immunotherapy, the idea is that we're going to give a tiny amount of the food in clinic and then supervise the patients and have them take that amount of food every day. And then we're going to see them again in clinic later and try to increase the amount. And if they can tolerate it, we're going to go home with that amount, and then so on and so forth until they can tolerate a portion of the food. So how does it work? It works in two ways. First, OIT disarms the mast cells. So how does it do this? Well, one thing I didn't tell you when I presented you the mast cells as landmines is that just triggering one IgE on the surface isn't enough. You need to trigger multiple IgE on the surface, and the more IgE you trigger, the stronger the reaction will be. The other thing is that when IgEs bind the allergen on the mast cell, so like I said, you need enough. So you need about 2,000 IgE receptors to be activated simultaneously for your mast cell to activate. The other thing, so the idea with OIT is that you're going to give a small amount of the food, so you're always below that amount. You're not going to trigger a reaction. You want to be below the threshold. The other thing is that when your allergen is going to bind these IgEs, your mast cell is going to eat up the allergen with the IgE. It's going to digest it, get rid of the allergen and the antibody, and it's going to recycle the anti-receptor on its surface. And then they're going to get rearmed with new antibodies, new IgE antibodies. So you say, okay, well, that was pointless. Yes, but they're not necessarily going to rearm with the same IgE antibodies. So yes, they might rearm with a peanut IgE, but they might also rearm with anything else that you're allergic to. So over time, if you expose yourself, imagine that the black Y's there, they're your antibodies against peanut. Well, as you expose yourself to peanut, you're going to consume your IgEs against peanut, but not the other ones. Are going to get replaced by other antibodies. Eventually, your mast cell is going to be desensitized. So what that means is that you're going to be able to eat more of the food without reacting. So there are tons of protocols for oral therapy, but they're all the same in the end. You start with a small amount of the food below the threshold for the patient to react. Everyone has a threshold. So some patients it's higher, some patients lower, but there's always a threshold. There's no patients that cannot be desensitized. We do it all the time for chemotherapy, for patients with cancer. We always end up desensitizing them. There's no question. Just we start lower, we go slower, but we always manage to do it. And it's the same principle with food allergies. We can start lower. So let's say this patient has a threshold at 5 milligrams. We're just going to start lower than this and have him eat the food. By having that patient eat the food every day, that's going to partly disarm the mast cell. That's going to bring the threshold higher. So we're going to be able to increase the amount of food the patient is having. And by doing this over some months and increasing progressively the dose, we're eventually going to desensitize them. So the patient's eating 2 peanuts a day, and by eating 2 peanuts a day, they're protected up to 20 peanuts. And I'm saying they have to eat it every day. And that's very important because during those 24 hours, you may have new IgEs that come arm your mast cell. So when they do this, that brings your threshold down. But because you're eating 2 peanuts the next day, you're bringing it back up. Let's say that you skip a day. So you wait for 48 hours, so that brings your threshold down a bit more, but you're still fine here. But in this case, in this patient, let's say that patient waited for 72 hours, so we stopped for 3 days taking their dose, and they had their 2 peanuts, and now they react. So with oral therapy, you need to have your dose every day, unless, because if you don't, well, you risk having your mast cells rearming and losing part of your protection. And you have to watch for cofactors, because that threshold that you tolerate in clinic, that's true unless you have those cofactors that will bring your threshold down. So patients have to be careful with physical exercise, fever, non-inflammatory drugs, alcohol, asthma, menses for female patients, and fatigue is a big one for students that are in their exam season. And what's interesting with oral therapy is that patients are actually going to have more reaction than if they didn't get treatment. Most patients don't react because they avoid their food. So the average rate of reaction in a year is about 15%. But with oral therapy, 95% of patients will experience some reactions and 5% will have severe reactions. So in the end, if you just look at this, well, that's a bad trade-off. I should just be avoiding. But the impact of OIT is not counted by the amount of reactions that you get, but the context around those reactions. When you're doing oral therapy, it is stressful. It is difficult to take that dose every day. It's nerve-wracking because you're really taking your poison as an antidote. So it is stressful, but that takes maybe your stress for 2 hours, but then for the 22 other hours of the day, you're protected. So you can actually let your guards down and you can enjoy life. And what's very interesting is that over time, even that 2-hour period actually gets better and better, because the more the patient takes a dose, they have small reactions, they learn about their reactions, they learn about their threshold, they learn how to treat it. They start giving themselves the epinephrine. It's not a big deal anymore. They don't wait for severe reactions to give it. It's just a drug to treat a reaction. And they actually become an expert patients because they gain this experiential knowledge of their food allergy. So I've had patients stop oral therapy after 2 years, and I spoke to them and said, oh, well, it's, you must be disappointed. And they go, oh, no. If I had to do it again, I'd do it all over again, because even though I'm not desensitized anymore, what I've learned from it makes that now I can actually live with avoidance much better than I could before. So this doesn't really have to do with threshold, well, kind of. But just to be complete, I'm just going to finish with explaining the other thing that OIT does. What it does is it re-educates your immune response, and that's not immediate. That's over time, over months and years. So initially, when you expose yourself to an allergen, like when you get a vaccine, you can stimulate the immune response. You're actually going to start producing more IgE antibodies. So, and we usually don't test it because patients are quite worried when they see the numbers go up, but they go up for everyone. But eventually what's going to happen is that the immune response, because you're eating it every day, you're exhausting the immune response, and the IgE production is going to start coming down. And after 1 or 2 years, you're actually going to usually have less IgE than you had to start with. And after 3 years, usually that's when you're going to get most of that benefit. So your white blood cells, again, the peanuts become exhausted, there's less IgE, and also you have a new population of white blood cells that start producing a protective antibodies, which is called the IgG4. And what that does, it doesn't arm the mast cells, it's just in your bloodstream. So, but what it does is that it competes with your IgE because it covers the peanut, then it's not accessible for your IgE, so it protects you against anaphylaxis. It doesn't protect you for local reaction, so in your mouth, it's still going to react because as soon as the allergen is going to touch the mast cells there, it's going to itch. In the stomach, same thing. But once the allergen enters the bloodstream, the IgG4 is going to neutralize it, and that actually really decreases your risk of anaphylaxis, of systemic reactions. All right, so that was all I had for you for the slideshow, and now we're moving on to questions.
All right, Dr. Bégin, that was excellent. Let's turn on our webcams. There's a lot of content there that I know people, I think it would be worthwhile for us to go back to a couple of the concepts just to make sure that we've got clarity of understanding. So I want to go back to, and some of the questions that came in was just around this definition of a threshold. So if you can go back to that and help again explain the relationship or what exists between the relationship of a threshold and severity. Okay, and
so
severity
the threshold,
yeah.
So the severity of reaction, well, it depends if we're talking about the severity of a reaction or the severity of the food allergy. So when you're having a reaction, the severity of a reaction is the symptoms that you get. But you could get severe reactions after eating 25 peanuts, but you don't get any reaction when you're eating 10. Would you define this as a severe food allergy? No, I think everyone agrees that it's not. It's just that you've ate so much that at some point you went over the top. So that's why when we define the severity of the food allergy, we'd rather talk about the threshold. But obviously, the threshold of a mild reaction is not the same as the threshold of a severe reaction. So in research, just to standardize, we say this is a threshold for a moderate reaction. But when we're doing the challenge with a patient to learn about his threshold, we should be talking about thresholds, because oftentimes we're going to start, and after eating a very small amount of peanut, it itches in my mouth. And then we say, okay, well, let's just wait it out. And if it doesn't do anything more than that, let's keep going. And then oftentimes we can go up quite a bit and actually reach 2 peanuts before they start getting other symptoms. So that patients which told us, oh, I'm super allergic, with traces I get reactions, they actually realize that, yeah, I sense the allergen really early on, but to actually get a dangerous reaction, I need to eat quite a bit of peanut. And that really changes their perception of their allergy.
Okay. And so why is it then that some people will react to a very low threshold, and it might be a mild reaction, where others are reacting to a higher threshold and the reaction itself might be more severe?
So it's probably just a question of how we did the challenge, because at some point there's always a threshold where it's going to start being there's always a dose response. So there's a threshold where it's going to be mild, and at some point it's going to reach a more severe reaction. So the patients that reacted with a mild reaction at the low dose, the thing is, I don't know what dose it takes to give them a bad reaction. And the person that reacted at the very high dose, I do know that a previous step, they're not reacting at all. So that is telling me that they have a high threshold. But the other one, we didn't follow through, so we don't really know the exact severity of their allergy.
Okay, so then, going back to the setup of this, when people ask you, well, how severe is your food allergy? Right? The school might be asking you, a restaurant, you're taking, well, how severe is your food allergy? What should people be doing to be able to better understand that?
So the first step is just to make sure that you do have a food allergy. So because like I said, just for peanut, 20% are actually not allergic. So the first step that you'll do with your allergist usually is just do skin testing and potentially some blood work. So that can be informative, because if it's really through the roof, we're pretty sure that you're reactive. That doesn't tell us how severe you are, though. Really, the only way to know how severe you are is to try the food. So usually allergists, I mean, they're not able to offer challenges to everyone, so they need to prioritize. So oftentimes they'll offer it to the patients they think are not allergic, just to get rid of the allergy label. So if someone comes and says, well, I want to challenge, even though I'm sure to react, I want to know how allergic I am, they might agree to do it, but they'll probably want to do the other cases before. But if you do it and you realize that you have a very high threshold, what we would do before would be say, oh, well, you're allergic, not that much, but keep avoiding it. Now we're changing to where we're doing things. Oh, wait, you reacted to 5 peanuts? Well, how about you start eating 1 peanut a day? So it's not really desensitization, because we're below your threshold. So I'm not doing anything, you're already tolerating it. But by eating it every day, that might actually help increase the threshold to even higher than 5 peanuts. And over time, maybe it's going to help with that re-education of the immune system. So more and more, this is what allergists are doing, because this is not exactly OIT, but it's, even if you consider it a form of OIT, it's really not requiring that much resources. So before, what we would do is we'd have this our own threshold for, let's say, IgE. We'd say, okay, below 2 for peanuts of IgE, we're going to offer a challenge, because we're at 50% chance when we're at 2. So overall, 15% of our patients are reacting. We're challenging enough. Now it's not that anymore. We're challenging patients with 5, 10, or even 15, because the question is not anymore, is the person allergic or not? Is how bad is this allergy? Because if it's not too bad, maybe there's something we can do and start introducing it, and that changes everything. And that tenfold rule, I mean, it's really important, because when you ask patients what's their objective before desensitization, oftentimes say just eating traces for me would make a huge difference. And that's really a big thing when they reach this. And when you look at this, actually half of patients might actually already be able to do this without having to go through the whole process. So
Right.
it's a
Okay.
low-hanging fruit.
Okay. So let's move on to a topic on if you have multiple food allergies. Okay. How does that change the conversation on thresholds and severity? Does it?
So obviously it complicates it a little bit because each of your allergen has, you have different amounts of IgEs against them, so you have different amount of severity against the different foods. If you consider the severity as how much I'm affected by the food allergy, well, if you have more food allergies, you're more limited. So obviously you're more severe in that sense also. But each of the foods have their own severity. So it's, what we usually see is the patient has one or two main food where their IgE is very, very high, above 100. And then the other foods, it's 10, 5, 2, 1. And lots of them, they're not even allergic to. And others, they might actually be able to tolerate quite a bit amount. And the only one they're really severely allergic to is the high one. So we call it cleaning up when we see a patient for the first time, and then we have this long list of allergies. We do the test, we do the IgEs, and we look, and then we start with the lower ones, and we go up and try to delabel those allergies that are not there, and identify the mild ones, which might be already at high thresholds.
And is there some allergens that are considered more likely to react at a low level than others, like a low threshold level, or like or that
It's really, I mean, epidemiologically, we know that soy and shrimp, like I showed, they're often false positive, and even if it's there, it's not a real allergy. But there's no food that by itself is less allergenic and that will react at the lower threshold. The reason for shrimp and soy is really because they're bystanders. That you're allergic to peanut, so you get a false positive in your test. You're allergic to dust mite, you're getting false positive on your shrimp
okay,
test because they're both arthropods, so they're
got it.
related.
Okay, okay. Now let's talk a little bit about cofactors. Okay, so there's a couple of questions that came in related to cofactors, and if, for example, this person has asked the question, can an athlete, should an athlete could consider OIT?
But it's something to consider, okay? Because we have some patients that have to drop out because they just can't fit it in their schedule. They train every day, and you need to take the dose every day and be careful 1 hour before, 2 hours after. Every patient is different, and some patients it really doesn't matter, and they can even run afterwards, and nothing happens. But some of them, especially those that have asthma on top of it, they do their sports and then triggers asthma attacks, and they just can't manage the two. And obviously the goal is not to tell patients to stop doing sports so they can do OIT, because you're just moving the problem elsewhere. So in those cases, usually what we decide is either they dose in the morning before their sport, or we just say it's not for now, it's for later. And oftentimes we say, oh, but we don't want to do it now. There's a window of opportunity to do OIT. And that seems to be true, but really for the earlier ages, when you're past 10, it doesn't seem to make a big difference. So if you're not doing it at 14, you could do it at 18 or at 25. It's fine.
And are the cofactors always an issue? Like, are you always, if you're exercising, are you always going to experience a lower threshold? Is that what the evidence would show?
Yeah, well, it is always. The issue is really that it interferes with your digestion. So it is going to help you absorb more of the allergen.
Right.
But will that translate into a reaction? That depends where your threshold is. Because when you're eating your 2 peanuts a day, you don't know where that threshold is. So if you do a challenge, you know it is 25. So then if you do, it should probably go down. But when we do just cofactor challenge outside of OIT with patients with peanut allergy, we see that there's a variety of reactions. Some people it comes down a lot. Some people it barely comes down at all. So and MENS is another example. We don't tell patients, female patients, to cut down their dose systematically during their periods. we just say it if there's a problem, because at least 2/3 have no issue with it. So
Okay.
it really depends from one patient to another.
Okay. So let's imagine a world where we can all know our individual thresholds and we're multi-allergic and we are buying a package off the shelf and we know what's in that package. Is there a way in terms of thresholds? So when you talk about traces, we think about that in Canada as may contain, and as we know, that's not regulated, it's guidance. But imagine a time where we actually could know exactly what is the potential threshold amount that exists there. Is there a way to estimate an individual's threshold dose to multiple allergens?
Yeah, I mean that's the really good question you're asking. And this is something that it's not new at all. We've been talking about thresholds for 20 years now, and the issue with the industry is that it's you don't know the exact amount. So even if I tell you, okay, your threshold's at 100 milligram, yeah, but how many milligrams of peanut is there in that specific food? And then when we ask the industry, say, okay, but how are we going to do it? How do you test thresholds in patients? And then allergists say, well, we don't, because we don't know the threshold in the food. So it's kind of a catch-22. But I think that things are moving forward now, and hopefully we're going to be able to get more information for the labeling to help us
Right.
use that threshold information.
Agree. Agree. And and that is actually work that we've got underway with food manufacturers, Health Canada, and Laval University, because it is complicated. And even the word trace is a problem, right? Because what's a trace, right? It's really it's a difficult definition. So let's go on to a couple of other questions that came in specific to OIT. So questions around, like, and this always comes up, Dr. Bégin, when we talk about OIT, it's like, where do we go? If people are interested in this, where do they go? If you've got someone who's 16, is that therapy something that it sounds like in your experience, it can work for all ages, but what's the path forward for folks in the different regions?
Yeah, the big issue with oral therapy is that we've had the research show that it works. But the problem is now, how are we going to offer it? And there's not enough allergists in the whole country to offer it to everyone now. So we're going to have to rethink the way we do allergy in the country, and we're going to have to work with the other specialists to do it together. I've worked with pediatricians in my hometown where they do their immunotherapy there, but I coach them, so I'm still involved. So unfortunately, right now, I can't say that anyone can have access if they want to. It's slowly changing, and it's starting with the easier oral therapy, because if you ask allergists who's doing oral therapy, about half will say they're doing some form of it, and
Right.
usually it's those high thresholds. They're going to start with it because they can actually manage to do it without too much resources. But as they do this, then what's going to happen is that they're going to want to do more because you see that it works. Then you're going to start asking for more resources and trying to find a way to offering it. So that's why we created that pilot clinic at Sainte-Justine with the ministry, just to give them established standards, but just to give them an assessment how much would it cost to offer it to the whole population. And the cost for what you're gaining is actually pretty low. But the problem is, even if it's a low cost, you're starting with a budget that's zero. Before the treatment was avoidance, do nothing.
Mm-hmm.
So even if it's a low budget, it's a lot of people, so the money needs to come from somewhere. So that's always complicated.
Okay.
So adult patients, usually we're going to, that we see here, we're going to keep them for research trials. So before I would do trials on whether OIT works or not, so people will be either in placebo or peanut, I don't do that anymore, because for me, it's clear that it works. There are other questions though. So how should we do it? This protocol versus this one. So at least they're privileged in the way that they're getting it and others are not, but they're also contributing to making it move
Right.
forward for others.
Okay. So I see that we're getting close to the end of our hour. So I have a couple of questions, and this one I want to address because it comes up often in our webinars, and it's really, and it's not specific to severity, but it is to treatment of anaphylaxis. What's the role of antihistamines? Can you speak to that? Because we get questions around, is Benadryl something I should be using in the treatment of a food allergic reaction and anaphylaxis?
So Benadryl is something you should just not be using, period. So it's a very old drug. It has tons of side effects, and people have the impression that it's very effective because it knocks you out, but it's actually slightly less effective than cetirizine, Reactin. So it's not good. It just has side effects. People say, oh, well, I take it at night because of the itching. It helps me sleep, but it's actually really bad sleep. It prevents you from going into the protective, the third and fourth phase of sleep. So it's actually like taking alcohol to help you sleep. So you're gonna wake up worse than you were the day before. So, and then the other antihistamine, the thing is, it doesn't really matter anyway, because they take at least half an hour to start getting absorbed by your stomach. And then they take 90 minutes to reach the rest of your body. So it's a non-question. It's not doing anything. So someone that took a Reactin 10 minutes later felt better. It was just supposed to happen. The only thing that's going to work fast is the adrenaline. So it works within 5 minutes. The peak effect is after half an hour, but within 5 minutes, you're going to start having the effect. And epinephrine works both by treating the symptoms, but also by stopping the mast cell. This explosion that I showed,
Right.
once histamine's out, it's out. There's nothing you can do. But if you look at a hive, it starts at one spot and starts getting bigger, because when you react, it's actually sending histamine to the other mast cell next to it, lowering its threshold, so that one start reacting, and it spreads like this. So the idea of you're starting to react, give the epinephrine is going to activate this receptor in the mast cell, and that makes the threshold go super high. So even if they see it's allergen, it's not reacting anymore. And on top of that, it's consuming the IgE, so you're actually desensitizing yourself while on the epinephrine. So that's why you want to give it early, even if you have the mild anaphylaxis. If you have an anaphylaxis systemic reaction, give the epi right away.
Awesome, thank you.
And also maybe, that's kind of off topic, it's very important. The epinephrine is not dangerous. The reason you're going to the ER is because of the reaction. So if you're wondering whether you should be giving the epi or not, but you don't want to go to the ER, give the epi and don't go to the ER.
Okay, it's interesting because I've seen the picture of the rabbit and the hare, a rabbit and the turtle rather, and the turtle is the antihistamine and the fast reactor is the epinephrine. So thank you for addressing that question. We really have to move on, unfortunately. So I want to just give you a moment for maybe if you've got 2 or 3 key takeaway messages for our audience before we end off the webinar.
Yeah, well, since this was about severity, I think that one message is that all anaphylaxis are not severe. Anaphylaxis doesn't mean severe, and the moment you have anaphylaxis, you want to treat it with epinephrine. You don't need to wait for severe symptoms to treat it. This would be my main message. And then just the other message is that thresholds do change, so you need to be careful, but they don't change that much. So it's worth experiencing with your allergen within safe limits with your allergies. It's worth learning about your allergy. You're going to live better with it afterwards.
Terrific. I can imagine that everybody's got lots of questions for their allergist at their next visit. So let's leave it at that. Thank you so much, Dr. Bégin. I know you're a very busy doctor, and we really appreciate your time and expertise on this topic. So I'll ask you to turn off your webcam, and I'm just going to have a couple of final comments for folks.
It's been a pleasure.
So as a reminder, you'll get a short survey through GoToWebinar immediately after this that will pop up on your screen, and you'll also receive a survey in email in about the next hour. So please take a moment to complete it because your feedback is crucial to us. It helps us understand what your questions are and design future webinars and really kind of take in the comments that you might have on these topics. So a couple of notes about some upcoming events. With the pandemic, Halloween will continue to look different than prior years, but you can still shine a light on food allergy during this time. In the coming days, you'll get information and that you can do to support kids with food allergies and create awareness of the seriousness of this condition. And there will also be a fun contest for you and your kids to participate in. So visit foodallergycanada.ca/shine a teal light for more details. In terms of webinars, what we have coming up before the end of the year is we are going to have a webinar coming up on cow's milk protein allergy. We also are looking to schedule in one webinar, additional webinar on COVID-19 vaccines to address the children under 12. And so please stay tuned for that. We will be sending emails out on that. As those of you in the audience are aware, Food Allergy Canada is a not-for-profit charity. We're completely reliant on donations for the support of the work that we do. Today's webinar was sponsored by the Walter and Maria Schroeder Foundation, the Sean Delaney Golf Classic, EpiPen, and the Peanut Bureau of Canada, and was made possible from donations of viewers like you. So to help us continue this type of programming, please consider donating what you can. Go to foodallergycanada.ca and you'll see the donate button on the top of the page. We'd really like to thank everyone for their participation today in today's webinar, and you'll be able to review a recording of this shortly from foodallergycanada.ca, and please feel free to share that with others who may benefit from this content. This now concludes our webinar.